This journey started with the rebirth of thalidomide, the first immunomodulatory drug that was found to be active in multiple myeloma. And this was a revolution that started in Arkansas by mistake. I guess it was not a planned revolution. The story behind this that most people know was patient-driven rather than physician-driven. And after the first report in NEJM from that group, a number of other authors were able to show that the drug was active, and we never figured out, I think, the right dose of the drug ever. But after that, a lot of stuff was done. It vanquished dexamethasone up front in the MM003 study. So it got FDA approval for frontline use in multiple myeloma. The combination of thalidomide and dex, however, failed versus MP in terms of improving overall survival. In fact, melphalan prednisone was better, perhaps because of the higher dose of dex used in the thalidomide arm. However, we kept at it at the elderly. And we have now, I think, 6 trials that were done comparing MPT versus MP using different dosing regimens of thalidomide, different dose durations. And some of them were positive, some of them were negative for survival. All were positive, literally, for progression-free survival. But in the Supreme Court of meta-analysis, it did reach the mark of improving overall survival. It actually largely disappointed before stem cell transplantation when compared to the then standard of care VAD and VAD-based regimens. It really didn't improve overall survival as in multiple randomized studies. And it had mixed results when used as maintenance after transplant. Once again, most studies showing an improvement in progression-free survival, but few showing a survival advantage. Lenalidomide kept the franchise going. We again bested dexamethasone in relapsed refractory disease this time, with both a PFS and OS survival advantage in the MM009 and 010 studies. This is what led to the approval of the drug in the disease. Then Rajkumar vanquished Alexanian in a trial that was not really meant to, but led to the death of, for most practical purposes, the high-dose intensive dexamethasone. As the initial study results showed an improvement in PFS with the low-dose dexamethasone arm, but like all curves, with longer follow-up, they did come together. Also, Rajkumar cut short Zonder's trial. That SWOG trial was abandoned after it was shown that low-dose dexamethasone was better. Zonder's SWOG study was looking at lenalidomide dexamethasone versus dexamethasone alone, and it did show once again that there was a better progression-free survival to lenalidomide dexamethasone. And a few years later, Dr. Polambo declared MPR a new standard of care in the trial that compared MPR to MP. It was a 3-arm study wherein MPR followed by R was superior to MPR and MP for progression-free survival. However, all 3 arms still with last follow-up have been similar for overall survival. However, we still needed to convince the EMA that lenalidomide is a drug worth approving in the frontline setting. So most recently, the MM020 study was presented, which has been talked about. Again, this audience I don't think needs an introduction to the study design. It was the first trial and the second abstract at the ASH meeting. And one thing to point out, Dr. Jagannath had mentioned moderating the last session that lenalidomide index can be given for long periods of time, it was a little bit surprising that in the lenalidomide dex continuous arm, about half the people were off it at 18 months, perhaps because of, again, the dexamethasone. I think in the real world, most people feel it can be given longer. The first trial, I think, just reconfirmed our biases as they existed. I think that for those that had any doubt, it certainly showed that RD was better than MPT. However, the thing is that for those who feel that RD till progression is better than RD for a finite period of time, we still have to wait, because at least with this trial, with albeit short follow-up, there's no difference in survival between RD till progression versus RD for a finite period of 18 months. The Dana-Farber marketed VRD better than VCD, and I think that it has become the more popular regimen. And then what about the post-transplant setting? It's the US versus the French. As you know, we have a trial that shows a survival advantage. The French, even with longer term follow-up, presented at ASH last year, did not show survival advantage, and they felt that the progression-free survival was shorter if given as maintenance therapy, and also the question of how long to give it. The Italians, however, are with the US. They firmly believe in the maintenance story, and maintenance till progression is dogma. Secondary malignancies, it certainly was something that, and remains something that, as Paul rightly put it, I think a storm in a teacup, but it bulked up many CVs, a lot of articles were written, a lot of presentations, and I think I'm not underplaying the problem, but I think that we have had drugs that cause far more malignancy without stirring as much concern. The IFM Dana-Farber study is currently ongoing, trying to address some other issues in this regard. Started out as friends with a similar trial design. Now I think the French have done their study, and the Dana-Farber study is proceeding on with some modifications in duration of lenalidomide maintenance. And this study, billed as a transplant versus no transplant study, will probably be an early versus late transplant study, but also will answer some of the questions in the more modern era. And then, obviously, the stamina trial was finished. This is the CTN study that also will answer the question of, once again, the role of consolidation post-transplant, and also revisit the issue of tandem transplantation. A new kid in the block is pomalidomide. Mayo got there first. They did a lot of trials, and they showed that the drug was active in a number of different settings, and with response rates even in relapsed refractory disease and dual refractory disease. Paul didn't like what the Mayo did. He didn't think that the 2 milligram dose was adequate. That was picked up from the Brits. So he wanted to dose escalate again and came up with 4 milligrams when given 3 weeks out of 4 instead of the 4 week out of 4 British regimen that the Mayo Clinic had adopted. And what we learned is that this works even in his hands, and it works in dual refractory disease as well. The French tried to referee. They looked at both regimens, and I think looking at whatever endpoint you want, you can support one or the other, but it seemed like perhaps the 3 week out of 4 had more people in remission for longer. So that's what made it to the FDA, and that's how the drug is in the packet insert. The EMA has a higher standard. It doesn't take phase 2 studies. So we finally showed it was better than DEX in highly refractory disease, and they were convinced, and they got it approved. And now we go again through the same stories. We're going to go and combine the drug. So PVD KPD, and a number of others to come. How does this drug work? Still, we do not know. Keith tried to tell us about the proteasome inhibitors, but he's probably better able to tell us how this drug works, perhaps through the cereblon story. And will he finish with Judah Folkman, by chance started by mistake as an anti-angiogenic drug, certainly has anti-angiogenic properties, but perhaps not what it is. So that's how the story started in Arkansas, with the patient being told by Judah Folkman to try thalidomide in highly refractory disease. But hopefully Keith will wind up the story with the drug, how the drug really works.